Thank you, sir, for that very nice talk with amazing videos. I'll just move on to medical retina. And this was actually meant for both PGs and for the general ophthalmologist, so it might be a little basic for the retina specialist. So what's a bird's eye view? Basically, I'm talking about ultra wide field imaging, and we all know that the background we had was this fundus drawing, which we all had to do to document things. And then the ETDRS attempted by the 7 standard fields captured into up to 75 degrees. And finally, we have the ultra wide field imaging where we are able to capture almost 270 degrees of the retina, not 360 degrees as yet. So these are some of the images that now we are used to, and you can see on the left side the healthy retina, and on the right side, just for representational purposes, and I cannot have all of them simultaneously, but the lesions that are possibly seen on the Optos ultra wide field imaging. So on the left you see the traditional fundus picture which we are used to, and just see the comparison. On the right side you can see the Optos image, the area which we can see with a single click, which has a wow effect. And the angiograms are also, they are quite amazing. You can see such neovascular fronts, on the angiogram. And also we are having the swept source OCT and the machines, wide field swept source OCT machines, which are going to be a game changer. And these are the kind of images which, this is a prototype, it's the Zeiss Plex Elite. I don't have any financial disclosures, but these are the kind of images which we will be seeing. So some cases, this is a case of PDR, well lasered, in the left eye, still active, having some pre-retinal hemorrhage and undergoing treatment with anti-VEGFs. And this is a case of CRVO in the left eye. And this is a case of IPCV, polypoidal choroidovasculopathy, with the PED and some bleed, which was treated with multiple Eylea injections, and it just dried up. And you can see the PED going down. And this is a case of a myopic CNVM. So in myopia you can have central choroidal neovascular membranes, which nicely picked up on the OCTA, which I think is quite invaluable in these cases. Another case of wet AMD with a PEHCR, which is a peripheral exudative hemorrhagic choroidal retinopathy, where you can have the disease which is not in the center, which is likely to be missed by traditional fundus photography and examination. RD, so not only in medical retina cases, but in surgical retina cases, it's very important to document. And for counseling the patient, supposing it's a macula on RD, how will you convince the patient with 6/6 vision to undergo a major surgery? So this is where this, Optos comes so handy, and you can show the patient exactly where the detachment is. And so that is the area of detachment. Autofluorescence, again a very underutilized entity, and OCT in the periphery showing subretinal fluid. And again a case of detachment, in the nasal part, where you can pick it up on Optos, and this is post-surgery. And this is another case of detachment with a large horseshoe tear inferiorly, and this is post-surgery with oil. So you can see and document and counsel the patient. A case of Coats disease with lot of telangiectasias, status post anti-VEGF and laser. And this is a case of FEVR, which we documented. A case of retinal capillary hemangioblastoma. So these are the classical pictures on the angiogram. But what again, so we need to take separate pictures with the traditional fundus photography, but just see what we can see with one shot of the ultra wide field, and you can document post treatment with anti-VEGF and sectoral laser, and the regression of the tumor in the periphery. So again, in high myopia, you can document lattice degeneration. For those who are refractive surgeons here, this is quite handy when you have to explain to the patient undergoing refractive surgery that you need to undergo retinal barrage laser before the refractive surgery is done. A very unusual case of a chronic optic nerve pit with maculopathy, and very dramatic presentation and on autofluorescence. So just see the amount of damage to the almost non-existent RPE. Then cases of fundus flavimaculatus or headomacular degeneration, much better seen on autofluorescence. A case of bullseye retinopathy, again much better seen on autofluorescence. So as I was saying, it's very underutilized, this autofluorescence. This is a case of a choroidal osteoma which we picked up after investigations, and you can see on the autofluorescence nicely the changes. And there was a choroidal neovascular membrane which was picked up on the angiogram, and patient was treated with multiple anti-VEGF injections, very recalcitrant to treatment. Nowadays we know that eye is becoming important in systemic diseases. I'll show you a few cases of systemic diseases that we have to deal with. So this is a young male with history of tongue chancre with VDRL and TPHA positive and multifocal choroiditis, and the patient was given 3 doses of IV benzathine penicillin, and this is how the patient progressed. And these are some changes on the OCT, and this is on autofluorescence. And this is the angiogram, and you can see the hypo areas, so many of them, numerous, much more numerous than was seen on the fundus photography. And this is after resolution of the changes. A rare manifestation of a grave systemic disorder, 9-year-old girl, gradual diminution of vision, pain, redness for 15 days, fatigue, anorexia, fever, arthralgia. Diffuse erythematous non-pruritic rash on the malar region, a butterfly rash. So I think most of you must have guessed it by now. This is the fundus picture with disc hyperemia, CME, peripapillary areas of graying, extensive perivascular sheathing, perivascular subretinal infiltration, and a bacillary layer detachment on OCT, and with a differential diagnosis of leukemia, anemia, and lupus retinopathy. Patient underwent investigations, and which revealed a picture suggestive of lupus retinopathy. Patient was subsequently treated with IVMP, oral prednisolone, oral hydroxychloroquine, intravenous cyclophosphamide, thanks to the help from PGI. And patient is now on follow-up and also is being treated with oral azathioprine. And this is after resolution, and you can see that the malar rash has gone, and the pigmentation on the palm is gone, and the CME has resolved. And patient is still continued on azathioprine, HCQS, and prednisolone. So I won't go into the details. Just last 3-4 interesting cases, I'll quickly go through them. So a leopard can't change its spots, it's called. And so a lady with history of recurrent vitritis over several years. Can you see in the left eye what remarkable picture of leopard spot pigmentation you can see? And this is the OCT picture with subretinal infiltrates. And in the left eye again on angiogram you can see a leopard spot retinal pigmentation. Most of the other investigations did not reveal anything much, including a PET scan, did not show anything major, and even endobronchial ultrasound with a biopsy did not show, just reactive lymphadenitis with a ZN stain which was negative. We had to do diagnostic vitrectomy, and thanks to RP Center again, where Dr. Rohan did this diagnostic vitrectomy, and which was positive for T cells, CD3 and CD4. And these are some of the pictures courtesy Dr. Seema Kashyap from Dr. RP Center. And we can see these CD3 positive cells. A case of bilateral primary vitreoretinal lymphoma. We treated it here with 25 injections over 1 year of intravitreal methotrexate with complete remission. Lumpy bumpy choroid. So you can see here this lumpy bumpy choroid on the left side here. This is classical, and you can see that the choriocapillaries have all been pressed because there's something pushing these choriocapillaries from down under. So the stromal choroid is pushing these choriocapillaries and almost making them atrophic. There are some speckles and some shaggy photoreceptors and subretinal fluid. And you can see very nicely on the autofluorescence these changes. Again, a leopard spot kind of picture with some mottled hyperfluorescence on the angiogram. And there was a past history of breast cancer. Patient was on Memofen tablet. Detailed systemic examination revealed choroidal metastasis and widespread metastasis in the body. Patient was put on chemotherapy with palbociclib, and this is the regression on the left side. You can see that this lumpy bumpy picture over time, over 4 to 6 months, has regressed, and this we recently published. So I call it Great Gig in the Sky or Dark Side of the Moon. That's a play on one of the Pink Floyd albums and names. And so you'd see a starry sky appearance. So this is very classical of a condition we call, I'll just come to that. So let me go through the history. 58-year-old male diagnosed elsewhere as CSR. So mind you, CSR, I'll show you the picture. CSR is not so innocuous as it looks. It's very easy to label some patient as CSR and tell them to come after 4, 5 months, 6 months. But that is very critical time when you see what happened to this patient. This patient had a history of renal cell cancer and had radical nephrectomy 8 years ago. And this is the kind of picture which I saw at first presentation to me, 624 in the right eye, 636 in the left eye. What is the giveaway? So these RP changes, can you see these RP changes? So it's like a starry sky appearance. And we sent the patient again, we took the help of RP center. Dr. Tityal sir is here, so I'm kind of thanking him again and again for having AIIMS, approachable, and Dr. Vinod Kumar helped us this time. And there was this choroidal infiltration with these RP protuberances and giraffe sign on autofluorescence. Past medical history, I already told you, had left nephrectomy, and at that time it was renal cell carcinoma, and on PET scan there was widespread dissemination of the tumor. Patient was diagnosed as B-dump, which is basically bilateral diffuse uveal melanocytic proliferation. It's a paraneoplastic syndrome secondary to metastatic renal cell carcinoma. Patient refused plasmapheresis, was put on chemotherapy by the neurosurgeon, and finally, unfortunately, went into closed funnel RD with neovascular glaucoma. And PET scan showed worsening, and patient refused external beam radiation therapy, was put on second line chemotherapy with everolimus, but subsequently was lost to follow up. So this we recently published in AJO case report. So again, just to tell you that any case with subretinal fluid, please do not just refer it off or just send it off as CSR, because these innocuous looking CSR can be something so deadly. Double trouble, so yet another lumpy bumpy choroidal conundrum, a patient with vision of 6/18 in the right eye. These are the Optos pictures again. So again, these wide angle, ultra wide field images, not showing you much. You can't really tell except for maybe something happening here in the right eye above the supratemporal arcade, and happening here in the inferior periphery in the left eye. But just look what we see on autofluorescence again. So you can see very marked changes of mottled hypo with hyper autofluorescence in the left eye inferior periphery and along the superior arcade and above the disc in the right eye. Gross choroidal elevation on OCT, similar picture to the one we had before, and you can see these shaggy photoreceptors with a lumpy bumpy choroid underneath it. This is what the angiogram shows, mostly hypo, and in the FFA you will get hyperfluorescence in the later phases. Ultrasound showing again choroidal elevation, subretinal mass lesion. Patient underwent all these investigations, and which finally showed patient was referred to higher center in view of the lung carcinoma, which was diagnosed on CT scan with metastasis, and the PET scan showed pleural effusion and widespread metastasized lung cell cancer, small cell cancer. So patient has been put on chemotherapy with paclitaxel, carboplatin and bevacizumab, is going to receive the second cycle tomorrow, which is the 11th, day after tomorrow at PGI, and is under follow-up. So this is the first follow-up. He's worsening. So you can see here now it is quite evident with an exudative RD. So the cancer within one cycle of chemotherapy has worsened. So the effect is starting to come, and the patient is continuing to be on follow-up. And this would be my last case, 27-year-old male, VDRL TPHA positive in 2019. And sorry, I think I did show this case earlier, so I think this slide is misplaced here. Thank you so much.